Good morning, everyone. So my name is Amy Byrne. I am with Western Tidewater Community Services Board, and today we are training on treatment planning, the basics. So we're going to talk today a little bit about the purpose of a treatment plan, how to develop a treatment plan, and kind of what goes into the treatment plan. And really, to start with it, what's the purpose? Our purpose for a treatment plan is working towards independence, rehabilitation of mental illness, and to help empower your clients with a great treatment map. And that's how I visualize our treatment plan development. We're going to start first with a video, and I do want to just kind of tell you a minute about that video. So the video we're going to look at today is about 10 minutes long. It's on treatment planning and counseling, setting goals and corresponding objectives. What I'd like, just to have a brief conversation after the video, is to look at what techniques the counselor used that you thought were helpful or helped draw out some of the answers that the client shared. So we're going to go ahead and start that right now. So what did you guys think of that video? What were some of your first impressions of it? You can put it in the chat or just unmute.
This is Michelle. It was very collaborative. He did a lot of checking in with her in regards to the things that she, identified for herself. He made sure that it was realistic and, something that she would be able to achieve.
Absolutely. Absolutely. I love the term collaborative because that's what it is. It's such a collaborative effort. How about anyone else? What else did you think? Or maybe any techniques that you noticed that stood out to you that seemed helpful? One of the things I had caught, I guess just to me in the chat, was the use of paraphrasing. Before I get into that, I really want, let me see what else. We have another one, clear language, clear language. He was very clear and how he communicated with her and how he checked on what she was saying. So we have clear language, we have paraphrasing. One thing that really stood out to me was he said, things that we've been working on in the last 4 sessions. And I said, wow, I really like that, because a treatment plan, and he challenged her thoughts exactly, Christina. The last 4 sessions was kind of mind-blowing to me, because a lot of people think we need to get a treatment plan going within the first few sessions, or we need to get it done at the very beginning. And that's not the case all the time. You have time to develop a treatment plan. You might have something a little more basic at the very beginning, but as you learn what the client's needs are, you are able to then begin to develop something a little bit more comprehensive, which it sounds like that's what he's doing. Let's see what else. He individualized every aspect of it. He absolutely did. One of the techniques I really thought was so helpful was the use of paraphrasing. And if you're unfamiliar with it, paraphrasing, it's such a direct way to show someone that their thoughts and feelings were understood. He utilized that in here. It helped her feel valid, respected. She's late on her assignment. She doesn't turn them in on time, but he did it in such a non-judgmental way that I think most of our clients, if not all of our clients, would truly appreciate. Paraphrasing is so important when it comes to those complicated, complex discussions, such as trauma. Words that our clients say can have more than one meaning. There are distractions, there are emotions that come out when talking about your problems, and how they are communicated is so important. And it also helps build trust. when you use paraphrasing. It helps the client know that they hear that you understand them or that you're working to understand them. And treatment planning is a conversation, which is exactly what Michelle said. When you hear it's a collaborative effort. Examples such as, if I hear you right, you're saying, so is it accurate to say, or it sounds like you expect this, or you intend to do this. So when we jump right through from paraphrasing into something that I very much enjoy, which is genograms. We want to find out how our problems got here. Are they new? Are they inherited? History, our family's history is vital to understanding our current problems. So what's a genogram? A genogram, it's a picture of a person's family or their relationship and its history. It goes beyond just traditional family trees that we'd see because it creates this visual pattern. It incorporates psychological factors that really affect an overall relationship. It's very useful. It's a tool for clients to help them understand in a visual manner the key people, the relationships, the patterns that are going on since as far back as they can recall. And some of our clients may have a troubling time with this. And I think a genogram is a perfect opportunity to keep and work on throughout your treatment with them. Keep adding to it as more patterns come about. You can see patterns in a pictorial way, and it helps guide the overall framework for them. Some of the questions when you're looking at creating a genogram is, what has been inherited? It may not have just started with you. Was it an inherited concern or pattern or issue? What is considered a pattern within a relationship, or what are problematic patterns or sequences that you discover? The use of a genogram is excellent in exploring those symptoms that they report. Therapists can help look at what is going on. Is something structural? Is it a systemic issue? Is it a relationship issue? And we can then decide how we're going to begin your treatment, how we can start working through creating a treatment plan. One of the best ways to start working through a genogram, once you kind of get all the pieces in place and at least the basics down, are utilizing open-ended questions. Open-ended questions promote a discussion. They promote you to ask someone to open up, share their thoughts, their knowledge, their feelings about something, whether they think it's relevant or not. And how they respond to that will help you continue to build on this genogram. Can anyone tell me what open-ended questions often begin with? What some of the basic first words might be?
You could say things like, tell me a little more about, and then that gives them the opportunity to, tell you about whatever particular situation. It doesn't, lead to like a basic yes or no answer.
Absolutely, yes. I also saw what and how. Again, I love that it doesn't lead to a yes or a no answer. It requires them to explain things. Describe to me a time. What was that like for you? Those are excellent examples of starters to ask open-ended questions. We don't want to start with, could you have done something different? Is there a reason you did this? Who did this? Those are very simple ways of getting a client to basically give you a simple one-line answer. It doesn't open up a conversation, and opening that conversation is crucial when trying to look at what we're going to work on and what we're working towards. So again, it's that developing an open conversation. What did you do on vacation? How was that like for you when they said that to you? How is it like living with this person instead of this person? And the hope would be that they would talk about it and they'd open up about it. It generates their thinking, their overall awareness of how a situation might have been handled. So a genogram is an excellent tool that you can start at the beginning of your treatment, but utilize throughout the course of treatment. Come back to it, reevaluate it. Do we need to add something to it? Utilize it as a tool, a continuous tool. So we're going to move on to really what should be in our treatment plans. So treatment plans comprise of 4 main areas: problems, goals, objectives, and interventions. And while the video we watched showed that he wanted several objectives to go with each goal, you do not need to be that complex. You're welcome to be, but it's not a requirement. We just want to make sure that we have objectives, which we'll talk about shortly, tied to our goals. So problems, that's the main area we want to look at. Those are the main challenges our clients come to. Typically, they come to counseling because they say, wow, this is a problem. This is what I have going on. So examples of different problems that you can use would be Sarah has a history of depression that shows itself as excessive sleep, poor hygiene, and not completing housework. You can also make that into multiple different problems depending on the situation. Something like, I worry all the time about not getting things done around the house. The use of quotes is excellent. You can utilize quotes because the goal is that we ask the clients, because this is an individualized plan, what are you working on? And I would expect they may not know all the words, depending on the population we're working with, but they would know, my goal is, the problem is I don't eat. And my goal is that I want to be able to eat at least a meal a day. And this is how I'm going to do it. So we want to make it easy for them. So I sleep all day and I don't normally get out of bed until midday. You can utilize quotes and that's okay, but make it something that is specific to them, the main problem that they see. So we all utilize the DLA 20. That's our daily living activities tool. And it has 20, if you didn't know that already, 20 awesome areas to evaluate. The DLA, it's a tool to provide insight as to our clients' strengths and areas of needed growth and improvement. We score folks on a range from 1 to 7. If you have a client that's in that 5 to 7 range, then that is an area of strength that you want to focus in on when you are working with them on a treatment plan or in just working with them in general. If they have a 4 or lower, those are areas of great conversation starters. I love to pick out 1 or 2 or 3. I don't like to go well above 3 areas that we can start working on immediately that maybe go together with one another. So what does that mean? So when we look at the DLA, I picked out a few areas that I find a lot of our clients may struggle with that also kind of link back to that genogram that we can look at. We can look at those patterns. So family relationships. If this individual, say Sarah, scored a 2 with gets along with family, has positive relationships with parents, siblings, child, or significant other family members, the question is, why is she scoring a 2? Where did that family relationship breakdown happen? And reflect back on that genogram. Productivity, independently working, volunteering, homemaking, financial self-support, a 3. Again, where did that productivity come from? Independently working. Maybe you didn't ever have to. Maybe someone always financially supported you and now you're kind of stuck now that you're an adult and you've individuated away from your family. And managing time is one I often see with adults and kids, following a regular schedule for bedtime, wake up, meal times, scheduling appointments, activities. I've had clients who have said, well, we never ate together as a family. And I'd say, well, what time, you guys didn't have like a normal 5:30 dinner time every night? Oh no, it was like a fend for yourself situation. My parents always worked. So when I look back at that genogram, I have a current pattern in mind that we can talk about. If that's how ideally they would like to live, did that work for them? How did that make them feel? And how can we change how that is for them and for their current family? So I love to be able to look at the DLA and those areas where improvement is needed and talk to your clients about that, about those areas, to see if any of them would be things that they would like to work on that may help resolve some of the problems that they're coming to counseling for. So we've talked about problems. Let's move on to goals. Goals should reflect an individualized, specific overview of your objectives. These are going to address the larger presenting needs of that individual. Your goals are long-term. What do you want to get out of counseling? You came here for a reason. What would you like to get from it? So goals, I like to say these should be person-centered, using very good words such as will or want. We can say things like, Sarah will get onto a better sleep cycle and will not stay in bed all day. I will go back to school and get my GED. With our kiddos, I want to be nice, work on sharing and follow directions. I will not cry every time my mom tells me no. I will find a job to financially support myself. So those are excellent ways of driving somebody to say, I'm going to do this. And that's what we want. We want them to feel confident in what they're doing, and using those words such as I will or I want will help make that happen for them with your help. So we move on to objectives. Objectives are the things that, our counselor at the very beginning told us, I like to have 4 for each goal. And by all means, like I said, you can do that, but that is not necessary. You can add objectives at any point, because objectives are these short-term, measurable, achievable, action, strength-based bits of tasks that you can do that will help you get to that long-term goal. And so while you might want to take that one task now and work towards it, you might need to add another task once one task is complete. So help your clients feel empowered by saying, you know what, you completed this task. Let's add another one. We're working towards that goal. And utilize those strengths from the DLA. You are great with money management. You are great in the productivity area. You are great with, your daily activities such as getting dressed, bathing. You have no problems with that. Let's utilize those areas to help assist in the development of those objectives. Many people write objectives in different ways, and a couple of the best ways to do them are SMART objectives or Roomba. I think Roomba was very funny, so I threw that in there. SMART are those simple or straightforward, measurable, achievable, realistic, time-framed objectives that you want. Or you can use the term Roomba, which would be realistic, understandable, measurable, behavioral, and attainable. Either one of those are great ways of looking at how to build an objective. And it sounds complicated. I promise it's not. We have an example coming up. But we want to work to develop small, simple steps towards those goals. It should be an accomplishment that your client completes an objective. I want nothing more than to go through a summary review or just in the middle of treatment and say, you know what, wow, excellent work. You did this. You should be so proud of yourself. You have reached this task. You finished it. Let's add another. We're almost to reaching your goal. So the building blocks and objective, I kind of broke it down like this because I thought it was easier to visualize. We want to have the person's name. This is a person-centered treatment plan. These are individualized. The use of the term client can be used, as some practices do. You can also use the name to individualize it. So in this instance, Sarah, using those action words, will or want, will manage her anxiety because that's what she would like to work towards. What? By using the coping skill of deep breathing. When, that measurable aspect, once a day in response to an anxious thought for the next 30 days. That's our measurable. And how is it going to be measured? How are we going to know she's doing it? Because it's reported by her through journaling and self-report. And that in and of itself is an objective. So Sarah will manage her anxiety by using the coping skill of deep breathing once a day in response to an anxious thought for the next 30 days, as reported by herself through journaling and self-report. And that is such an easy way of building an objective for yourself. It sounds long. I promise you it's not as long as it sounds. But that is just a great way of making sure that we capture what we're working towards, how we're going to do it. We see the measurement of time and how we can measure it. So through her journaling, through her self-report. And that's an important piece, as well as how we're going to know someone's doing what we're asking them to do and what we're working towards. So the self-report, the journaling is so helpful. So we're going to move on next to the last piece of the treatment plan, which is the intervention. So interventions should define the specific steps the provider and the individual will take towards the attainment or achievement of each objective. The intervention, again, is what the provider is going to do to help you. They are based on the individual's specific strengths. So the clinician will help do this. While it is a work in progress, you both are working together, it's how the clinician will help you. And it should clearly reflect the care coordination with others. And if you're working with kids, you are often working with parents and caregivers, making sure that if you have an intervention that works with the parent and the caregiver, that the intervention is specific to the goal for the child. Or if it's an adult with a guardian, making sure that the intervention working with the parent and caregiver, again, is very specific to achieving the goal within the time frame that the client wants. So a few different examples of interventions. You can write them however you'd like. They could be very simple. Some of these are clear. The clinician will assist Sarah in increasing her desire to complete short tasks, increasing the tasks in frequency over the course of treatment. Completion of these tasks will be monitored by self-report and journaling. Wow, Sarah does like to journal a lot and talk a lot and give you self-reports, which is good. You want that. Family therapy will be used to explore and help the family understand better communication techniques instead of using the word no. I love that. We work with so many families, and families struggle with how to redirect without using the word no. So this is a perfect example of how to incorporate that intervention in helping the child. And the third example is individual therapy will be used to process and resolve Sarah's feelings about family members and reinforce the use of good communication and conflict resolution and coping skills. So those are just a few examples that we can work on. The next section we're going to move on to is one I feel is the most important, and it's discharges. And the question is, do I have to? And yes, you do. Discharges. We love our clients. We want to spend time with them and work through all of their problems with them. But at some point, treatment has to end. And I just had a conversation with someone recently who had mentioned that she was doing a summer review, and she started, openly talking about discharging, because that is something that's part of your treatment plan, is discharge planning. And I think he got a little, his feathers got a little ruffled, because I don't think he was expecting to be talking about that. And if it's not something that's openly discussed from the very beginning, it can feel like, did I do something wrong that you don't want to see me anymore? And we don't want our clients to feel like that. So while it may be heartbreaking to hear that we do have to discharge, we are here to help our clients work on improving their lives, helping them develop the tools to navigate life independently. And that's our main thing. Now, some of our clients, we may not be able to completely rehabilitate, such as those living in an assisted living facility or who are severely impaired, but we can work on putting pieces in place to continue to support them, such as through that treatment plan. And oftentimes we don't assist the clients in discharge planning from the beginning. We want to reinforce the idea that end up reinforcing the idea that they can stay with us as long as we want. And so we end up having annual plans with our clients because they just don't leave. And oftentimes we don't know what we're working on. And taking a step back and saying, hold on, what are we working on? That's so important during those summary review times and throughout treatment. But we must prepare for discharge from the beginning of treatment and using it as an open conversation. So discharge goals. All treatment plans require a discharge goal, and this should be individualized to them. This will show that when a client is ready for discharge and what is their plan to step down out of your care, because they can't rely on you forever. Effective discharge planning is there to decrease the chance that a person re-enters treatment for the same identified problem. We know it will happen, happens all the time where people come back to us, but we want to make sure that they are set up for success, that they have pieces in place that we have worked on, that their DLA is reflective as strongly as possible, that they are within normal limits, as we would say, they're scoring those 5s, at least maybe 6s. I don't know a lot of clients that are scoring 7 because I wouldn't score 7 on a lot of things, but that they are at least achieving, normal ranges of functioning. So we want to get them there through discharge planning. So what do we think about when we think of a client, whether they're in outpatient or they're in case management? A few questions you might consider when writing in a discharge plan for your client. And I say plan because it really should be a plan. A lot of our staff and clinicians say, well, I've got a discharge goal up there, but that's not really what we're talking about. A discharge goal is okay to have because the goal is that they're discharged from therapy because they've maintained their goals, but I don't really know what that means. And I don't find that as a supportive plan for the client to leave and be successful independently back in the community without our supports. So a few things to consider when writing a discharge plan on that treatment plan. Medications. Are they taking medications? Who's prescribing it? Are they in the care of a private provider, their PCP? Do they need linkage to one? Maybe they're enrolled in your medication management department at your CSB, but if they get discharged from your care, medical will also discharge them within a certain amount of time. Well, are you going to work with the medical provider to ensure that everyone is on the same page about discharging? That is something vital to think of because oftentimes our clients will hang on because they don't want to lose that medication support. Another area to look at, social supports. We have clients who come in that families in disarray, they don't have friends, they can't maintain friendships, they don't know what to do with themselves during the day because they don't really have anyone. So have we worked with them to make sure that there's a support system in place? Do they need linkage to continued supports like NA or an SA support group? Do they want some, monthly support groups that are in the community working on their topics such as anxiety, shopaholics, anything like that? If they need those, how do we connect them? Because we as counselors are not the first line of defense when something goes awry in their life. They can't always just pick up the phone and talk to you immediately necessarily. They need other people to rely on. They need people to be able to call and say, hey, I'm having a difficult day. Can I talk to you about it? And having those people in place that say, sure, tell me what's going on. That's what we mean when we talk about the support system in place. Because when we don't have a support system in place, we feel rejected, we feel lonely, we feel hopeless and helpless. So again, thinking about those social supports. Are they being discharged out of a rehab service like case management? Are they stepping down to a singular lower level of care? Will they continue in OP? All things to think about. If they lose you, if they're discharging from you because they've met their goals, how are they doing in case management? That's where coordination of care is so important. And then that linkage to other providers. Do I need to help them link to other providers? Are you working closely with other providers to make sure that plans are in place for them to be successful? If they leave you, do they still have those other pieces in place? If they do, excellent. But not everyone has someone in place. Maybe a client is ready to be discharged from everyone. So working together to make sure we have the supports in place, that they're linked to providers is very vital to their care and their success. So like I mentioned, care coordination, it's so important that we work together as providers, as counselors. Maybe someone has a family therapist and an individual therapist working together, or in general, just with case management, like a rehab program. But all treatment plans should clearly include care coordination as a necessary step in improving the individual we serve. Treatment plans should clearly identify all current professionals involved, such as educational parties. So the school system, maybe they have an IEP. If they have a case manager, they're on probation. Maybe they have neurological issues that we need to work through. So we want to make sure that's documented. Psychiatric help, social services. And care coordination activities must be defined related to the specific treatment needs. So we want to look at what somebody is providing, whether that's outpatient, foster care, probation, or other mental health services. So we want to make sure that the specific treatment needs and coordination efforts, you're working with all of those parties. So the question is, what more can I think about? That was a lot to digest, and I know it was. What's in place to ensure their goals will be met and maintained? Some might say, well, it's not really my problem. Once they're gone, they're gone. But I hope most don't think like that, because our goal is success. Our goal is that I never see you again. And that I say that in the nicest way, because our goal is that you are set up for success and that we have worked hard on what you needed to work hard on, and you took away what you needed to take away, that you are successful and you can go on and feel like an independent individual in our community. But if you do need to think about more, we can think about who they should contact in the event they need help. Again, that support system. Who do they have? Do they have family? Do they have friends? Household care. Do I need to address or set up any ancillary supports for them, or assist them in identifying the needs that they have? It's good to work through problems that they might have and work towards goals. But if I leave you with needs such as, I don't know how to manage my money, or I don't know how to cook, I eat microwaved meals every day, but I've gotten you to eat 3 meals a day at least, but they're microwave meals. How can I help you a little bit more? So do I need to help set things up for you or link you to services? Emotional care, companionship in place, meaningful activities, work. What kind of community activities are there for you? How can I assist you in being able to locate those? My job might not necessarily be to call all these places, but my job is to empower you to be able to find those. Medical care. Again, one of the biggest areas we find our clients struggle most in is with that medication management, physician's appointments, physical therapy. Gosh, we have clients that see so many different treatment providers that it would be overwhelming for me. And having an easy way of tracking appointments, what numbers to call. Again, our goal is to empower them. And while it may seem like, well, this sounds like case management, a little bit is. We want our clients to be successful, and we are here to help them set up tools to be successful. So setting up a calendar, having an emergency contact list or a medical contact list, especially for folks with a lot of medical appointments or just appointments in general. And how do we empower them to make those own calls? We want to help arrange a follow-up appointment for them, maybe for the first month or two, by helping them learn to independently call. I've had clients previously where they needed something and they're like, well, can you just call for me? Well, no, I can't call for you, but I'll dial the number. If you tell me what number it is, I'll dial it. But we need to work through what you're going to say to them and how you're going to say it and how you can ask and empower yourself. Sometimes we get nervous when we're on the phone with people or we don't know what to say. And as a young child, I used to write everything down, even the basics of ordering a pizza. My parents would say, you need to learn how to use the phone. write down what you're going to say, call the number, and read it off the script. And sometimes that's what we have to do with our clients. So that's a lot about care coordination. We're going to move into safety planning and the specifics. So safety planning goals, or crisis goals, as we can say, it is a requirement on a treatment plan. For any client with a history of suicidal ideation, homicidal ideation, or any history of hospitalization, maybe a suicide attempt, it is required, but it's always such a good thing to add in there, even if they don't have a history of those, just in case. For each incident a client vocalizes threat to harm themselves, or they vocalize that, I cut myself, a safety plan should be reviewed and documented in a progress note. We should make sure we review that safety plan, but update a Columbia risk assessment. We have access, most agencies have access to a Columbia risk assessment, and it should be reviewed and updated with them to make sure that our bases are covered. And if a client is hospitalized for self-harm or vocalizing self-harm, the Columbia is required if it wasn't already in the chart, and an update to the safety plan should be made on their treatment plan. And it's not as simple as just saying a safety plan was reviewed, but really developing a safety plan. You cut yourself because you were overwhelmed, you were anxious, but what could we have done? What can you do next time? Okay, you're going to do this. Okay, and if that doesn't work, what are you going to do next? And after that, what will be your next step? And we're trying to delay them harming themselves. We're trying to draw it out, because the longer they can go without doing it, the less likely they are to follow through. So a few examples. Sarah will develop a safety plan to support her in stopping cutting. Sarah will no longer harm herself by cutting. Sarah will not require additional mental health hospitalizations, or quote it. I love it. I won't go back to the hospital because I will feel better. Those are excellent goals. Some of the objectives to tie to that. Sarah will reduce her cutting from 3 times a week to 1 time per week within the first 90 days. Now, 90 days may seem like a lot. I use that here as an example. You might choose, based on her risk, to do in the first 30 days or the first 60 days, but make it measurable and make it time limited. Again, you can use quotes. I will stop cutting my usual 3 times a week, which my clients probably wouldn't have said it like that, but I wrote it like that, and get down to no more than 1 day a week in the first 90 days of my counseling. Use their words. That was a fancy way of writing it. My end goal in a treatment plan is I can say, what are you working on? And they can tell me what they're working on in their own words. And that is totally okay to write in a treatment plan. Another one would be, I will create a safety plan to support myself within the first 30 days of treatment. We create these things called crisis plans. Some find them helpful, some not so much. They're a documentation requirement. But a crisis plan and a safety plan really can be 2 totally different things. But you can put in place a true safety plan. What will happen when I'm feeling like this? And you can put that in your treatment plan. You can add that to the crisis plan. We want to make sure it's very much accessible, and we can refer back to it. I know you called me last week because you were cutting and you ended up in the hospital. I'm happy you've returned to services today. Let's pull out the safety plan and kind of see what didn't go as well. Okay, well, you got upset and you said, I'll call my mom because that's what's first. She didn't answer. So you just went to it, but you have 3 other things that you could have done. What happened there? And we can talk through the frustration of mom not answering, or that you felt like if she's not going to answer, nobody else cares. We can talk through those things, and we can enhance that safety plan, or we just want to reinforce what's already there. So we're kind of moving to the end here. We're going to talk a little bit about treatment plan, our individual service plan summary reviews. So for outpatient counseling, for mental health outpatient, our summary reviews are due every 90 days or every 6 sessions, whichever comes first. If that's not confusing, I don't know what is. For SA outpatient, a summary review is every 90 days. It's due every 90 days, calendar days. Case management summary reviews are every 90 days. Now, one thing to keep in mind when you complete a summary review early, your 90-day timeline starts from that new date of review, not from the original date. It can get tricky. Always ask for help if you have any trouble. And if you'd like to update a treatment plan at any time, which you can do, and it's highly encouraged by adding goals, ending something because they've achieved it, changing items, marking it as complete because there is usually a way to mark a treatment, a goal or an objective as complete. A review is needed, and you can wait until the review timeframe, or you can do it early. You are never penalized for doing it early. Again, the goal is that we recognize the strides our client take in the treatment process. Utilizing the summary review is so excellent. There is nothing better than saying, great work, you did it. Let's move on to the next thing. Or let's take a breather. Let's take a breath and reflect on how much work you have done in the last 90 days. Overall, we're here to assist in developing our clients with a roadmap to their success. We're here to assist in that achievement. They must put in the work to achieve it, but our treatment plan is the tool to help guide them towards success. So the homework that I'm giving you today, because I believe discharge planning from the beginning is so important, I'm asking that you reflect and document the importance of discharge planning from the beginning of therapy services, and write down how you would introduce this to your client at the first session. It can be a little tricky, it can be a little scary, but I'd like you to write down how you would introduce it at that first session.